This is where we left off, and I think we were talking about the left side image. We want to move on to the right side image, what happens between so the left is external respiration, the right is internal respiration. Internal respiration, what's happening here again is based on a concentration gradient. O2 is going to come off oxyhemoglobin molecule is reversible. It's going to break apart, free up that oxygen. Oxygen is going to diffuse into the cell. CO2 is going to diffuse into the plasma. It's going to mix with water in the plasma with the aid of an enzyme, turn it into carbonic acid, and that can then be converted to hydrogen and bicarbonate ions. Particularly that bicarbonate ion tends to be a big part of your buffer system. Or some of it can be carried on the red blood cell in other spots than where oxygen is carried. But most of carbon dioxide is dissolved in the plasma. That's how it's carried in the blood. The mechanics of breathing, otherwise, it's time to explain why do these airs change? Why does it go in and why does it go back out in terms of air? So we have to get a little bit more specific about that. It is based on changes in volume, so it's a mechanical process. Volume, so size of the thoracic cavity, and you can physically see that on yourself, that when you breathe in, your thoracic cavity expands in size, and when you breathe out, it contracts in size. The volume changes lead to pressure changes. So you have the definition of atmospheric pressure is the weight of air is the atmospheric pressure, and that's 760. It tends to be what it is, milligrams per milligrams of mercury. And what happens is, and it's actually a very, very slight negative, is as you expand your thoracic cavity, you have a negative amount of negative pressure compared to what's outside in the outside world inside your thoracic cavity, and so air comes in. Again, it's just down a pressure, concentration gradient. And one of the things that we think about in terms of breathing is inspiration is flow of air into the lungs, expiration air leaving the lungs. But you have a couple of laws and then something to understand about the air that you breathe, because you don't breathe pure oxygen. And each of the gases that are part of the partial pressure of air have their own role to play. But one of the laws, Boyle's law, so it tends to be a question that gets asked, is that volume and pressure are in inverse proportion. And what that means in layman's words is the bigger the area that something can be in, the less pressure it will be under. And I'm sure all of you have experienced this. If you have a family of 6 living in a house that has 2 bedrooms and 1 bath, there's going to be a lot of pressure on that bathroom. But if you have a family of 6 living in a house that they each have their own bedroom, their own bathroom, not too much pressure on any individual bedroom. So it's very, very easy to understand. The closer these particles are being expected to be together, the more the pressure will be. So this is Boyle's law, that it's in inverse proportion. As volume increases, pressure decreases, or as volume decreases, pressure increases. That's the inverse proportion, Boyle's law. And then furthermore, lungs have this compliance. We talked about this a little bit already, in the fact that they compliance would be a measure of the lung's ability to stretch or expand. If you go back to remembering about the thoracic cavity, remember the lungs are covered by the visceral the visceral pleura. That visceral pleura, then you have the space in between, then you have the parietal pleura that then is attached to the thoracic wall that is expanding the size of the thoracic cavity. But lungs, by their definition, have this ability to stretch and expand and fill the space that they are being asked to live in. It's kind of like a sponge. If you put a sponge in a small container, it'll stay small, but if you put a sponge in a larger container, it will expand and fill that whole container. That's compliance, a property of lungs. You have another property with regard to lungs. It's elasticity. That's the ability to recoil. And that's thanks to those elastin fibers that are around the alveoli. So lungs can expand and contract based on their design. So based on their design, the things that affect this is if one has if your connective tissue is not mobile, and particularly you can get connective tissue that's not so mobile, a lot of times in the back, in your back area, not so much of the lung field, but the fact that this whole cavity is not, the thoracic cavity isn't expanding as much as it has in the past. The level of surfactant, if surfactant isn't facilitating the resistance, so making the resistance less, and then motility of the thoracic cage, and that kind of goes with the connective tissue. But this picture, which does not come from your book, I thought was kind of interesting because it's showing you the effect on compliance of having visceral fat. I'm sure you hear about this all the time, and they talk about how dangerous visceral fat is to our health. And what they mean is fat that's packed around the organs. And right here in kind of an artist's rendition, you have fat that's pushing against these the lung fields. And of course, you know, it's not realistic. You have your thoracic cavity there and everything. But all of that is trying to push against that fat, and it restricts lung capacity. And we do see this in people who are obese. Sometimes they have restricted lung capacity. I guess you can't generalize about things. This image comes from your book. It's not 23.15 in your book, but I did like this way it showed everything together. Ventilation is commonly referred to as breathing, but remember, ventilation is just the air in and out, which we divide into inspiration and expiration. It flows in or out because of pressure differences between atmospheric pressure, which is the pressure of air, and the gases inside the lungs. Some of the terms that we look at are atmospheric pressure, which we have defined, intrapulmonary pressure, sometimes known as intraalveolar pressure, and intrapleural pressure. And we'll look at that. We'll look at the definition of those on the next one, but what I want to do before I do that is look at a little bit what this picture is showing you. Up on the top left, you have a side view. You have your spinal column. You have your rib cage, which you know your rib cage interface with the spinal column in the posterior, the sternum in the anterior, or the cartilage into the sternum. So what happens is that rib cage lifts, and you can just barely see it here, but the bone portion, so the tan bone portion, there's also a I guess a dotted line that shows that it lifts and expands, and then that diaphragm contracts. I know maybe I said it right in the beginning. I'm not sure. I don't remember anymore. It contracts, but you can see how that would actually increase the volume there. Remember, if we increase the volume, then now we have a net negative with regard to pressure inside the thoracic cavity compared to the atmospheric pressure, so that's going to cause air to pour in. And then you can see on the top right, the two lung fields. what's happening here, the pressure in and out is equal, so nothing's happening. And this is what happens at the apex of inhalation and exhalation, is you have this equalization, so nothing happens until the rest of the cycle happens. And then if you have volume decreasing, pressure inside falls, so air moves in, so volume increases. Sorry, I think I maybe said it wrong. So volume increases. If we're on the bottom left, volume increases, air is going to flow in. Volume decreases, air is going to flow out. And here you have the idea of what atmospheric pressure. Atmospheric pressure is the pressure of air, and that's what's coming in, what's pushing down on your trachea. Intraalveolar pressure, that's the pressure of those alveoli pushing out. And so the air came in and expanded those alveoli. So they are pushing out against the intrapleural pressure. And that intrapleural pressure is the pressure between the visceral and the parietal portion of that serous membrane that's around the lungs. And you have these pressures all working together, and basically they stay in a negative. They stay in a negative in the negative numbers to keep a slight inflation of the lungs. The lungs always stay slightly inflated in a normal, healthy individual in terms of the pressures. So terms to kind of have in your head. I honestly don't ask a specific question about any of those terms, but just to have them in your head. Intraalveolar pressure, the difference between atmospheric pressure and intrapulmonary pressure is small. And so, and actually any of these changes in pressures are very small. We're talking about very small margins here. And then with regard to inspiration and the muscles of inspiration, diaphragm and intercostal muscles contract, the size of the cavity increases, and so air is pulled in to the lungs due to increase in intrapulmonary volume. Just makes sense. We just talked about this. The only thing we've added is refreshed our memory about what muscles are used here. The diaphragm contracting, intercostal muscles contract. That lifts that rib cage, opens it up. More volume inside the thoracic cavity, and so air is going to be pulled in. Exhalation is a passive process. And so what happens is all those muscles relax. It's a passive process. Depends on the elasticity of the lungs. Muscles relaxed. Now you have an increase in pressure in the thoracic cavity. That's going to force air out because it basically has more space out there. So the pressure gradient now has increased. So pressure has increased. So it's going to force it out. Forced expiration, this is if you want to force out more than what is normal. Normal breathing is tidal volume. Tidal volume. And that can happen if you contract more muscles. And sometimes you see that on people who are air hungry, or they have respiratory problems where they're actually recruiting other muscles to actually breathe in and breathe out. But a lot of times that's breathing out. They're trying to get the CO2 out. It has to do with the fact that most of the feedback system is based on carbon dioxide, not oxygen. We'll talk about that, but most of the feedback system in terms of setting your rate, rhythm, and your depth is based on chemoreceptors that pick up carbon dioxide levels. Then other muscles are the transverse thoracic. The abdominal muscles also can come into play, as well as the scalenes, the pectoralis minor, and pectoralis minor and your Yeah, your pectoral and your scalenes. I was trying to think of another one that comes in. Particularly you think of with somebody who has, unfortunately, emphysema. And just to reiterate, the pressure differences